Okay, sir, I'll wait.
Please 3 by my watch.
Yeah. 1 more minute, we'll wait, sir. I missed Dinkar Pai's session, sir. I'll watch it in YouTube today. Last week I was not here.
She made it a point to avoid my talk.
Sir, nothing of that, sir. For a long time I was asking you, right? That was one topic which I wanted to hear. I'll go and watch in YouTube.
Sure, sure.
I too missed yours, Dr. Dinkar. I was in the flight at that time. Otherwise, my attendance is 100% all the time as the head of the institution.
You didn't miss much, sir.
Yeah. चल महालक्ष्मी शुरू कर दो.
Okay, sir. Good afternoon, friends. It's a Friday afternoon, and we are back from the Scientific Society of AVMC, Constituent College of Vinayaka Missions Research Foundation. We are back with another episode of our FFF webinar series, that is the Forefront of Future Frontiers, a medical webinar series, which is ongoing since every week from May 2020. And today we are now in series 15, episode number 96. The theme for this series 15 is on recent trends in medical education. And we have with us as speaker, Professor Dr. Zaleha Abdullah Mahdy. She is a professor and senior consultant from the UKM Medical Centre, Kuala Lumpur, Malaysia. So she is going to talk to us about teaching teamwork and non-technical skills using simulation. And for this particular session, we should thank Dr. Dinkar Pai, who is our visiting consultant to the Simulation Center, who has actually helped us to get the speaker. And before we proceed, I'd request our Dean, Dr. Kotur, to welcome the gathering and Dr. Dinkar Pai to introduce the speaker. Over to you, sir. Sir, you have muted yourself.
Yeah, thank you, Professor Mahalakshmi. I am indeed honored and privileged to welcome today's speaker, overseas speaker, Dr. Zaleha Mahdy from Malaysia for this 96th episode of the FFF platform, which was established in the beginning of the COVID pandemic, and day by day it got strengthened, and we have a wide database exceeding 15,000 across the globe, and various eminent scholars, teachers, academicians, researchers have shared this platform, sharing their knowledge, sharing their expertise on this for the benefit of the overall the medical fraternity or health science fraternity. And our humble effort was to drive away the claustrophobia during the pandemic, COVID pandemic. But then later on we realized, it is really we are heading towards the 100th episodes. It's only 4 episodes away now. We are really ready. We had a silver jubilee, we had a golden jubilee, we had a platinum jubilee. Now our 100th centenary episode is only a month away, and we are already having the eminent person for that. This is about the FFF platform, which has brought the Adaptability Medical College, Pondicherry, India, in the international map, of this fraternity. This is the credibility we have established. And I, on behalf of our management, Honorable Chancellor, Madam Chancellor and Board of Management, and our university at large, welcome today's speaker, Dr. Zaleha Mahdy. And I find it appropriate to share a few thoughts on this occasion, just to give a preamble for the today's topic. First thing is about AVMC. We have got a very vibrant medical education team. Medical education team of acclaimed educationists, well trained in India and even abroad. And the medical education team with these experts have been conducting various faculty development programs, and this recent trends in medical education is quite relevant to it, and MEU of AVMC has been a part and a parcel of it. That's one thing I like to say. And keeping pace with the changing world with the introduction of the competency-based medical education across the entire country of India by the regulating council. Like any other colleges, we are keeping pace with this implementation of the competency-based medical education. I rather say with our team, vibrant team of experienced persons, we are, I will say, a step ahead of our all sister institutions. This I can vouch on that. That is possible because of my AVMC team. And now this topic is of special relevance to us with our vibrant medical education team, because now whatever reforms have been taking place in medical education across the globe in the past several decades, one of the reasons for the change has been the patient safety, wherein the role of the simulation came in. Because apart from other reasons to keep pace with the changing technologies, changing needs of the society, changing disease scenarios, all kinds of things, among them this patient safety is one. We all know that significant 3, 4 to 5% of the patients who get admitted will have a kind of a morbidity and mortality related to the during the teaching and the training, especially the life-saving skill to the trainers. So this is how the simulation-based training has many advantages. Apart from that, apart from imparting the competence to the students or the trainer, be it a UG or a PG, it has a very definite, concrete, much needed advantage of offering patient 100% safety with the trainer having multiple repetitions of practicing that skill. Now, like any other teaching skill, the simulation-based teaching skill also requires some kinds of the additional skills. Okay, of course, teamwork is not new to the medical fraternity. When you are doing a teamwork, whether it be it a clinical work or be it work outside in the community, teamwork has got a definite advantages. Teamwork has got a definite outcomes. Now, in this furthermore focused area of a teaching of a teamwork in a simulation-based training, when you are teaching technical skills in simulation, and the non-technical skills come, soft skills also come into play. So we have a ATCOM module which will take care of many skills during teaching and training. But this today's speaker, very much focused of taking care of the non-technical skills. Those need to be inculcated or mastered by the trainers. That's one. And then of course the role of the teamwork. Such a focused, interesting topic, relatively kind of a little new perspective for this entire thing. Our experienced speaker shall probably be sharing today. So with these few thoughts on this occasion, I welcome once again Dr. Zaleha and all the esteemed participants over here, my colleagues, Dr. Bhatt, Dr. Mahalakshmi and other HODs for this wonderful meeting of teaching teamwork with non-teaching technical skills used in simulation. Over to you. Thank you. Over to you, Dr. Dinkar.
Thank you, sir. And I would like to thank Dr. Mahalakshmi to give me this unique honor of introducing Professor Zaleha Abdullah Mahdy. Prof. Zaleha is an obstetrician and gynecologist by profession, and she's a member of the Royal College of Obstetricians and Gynaecologists, and also has a unique distinction of having a doctorate in medicine from Newcastle University in the United Kingdom. Her special interests are in maternal fetal medicine, specifically in preeclampsia. She is now professor and senior consultant obstetrician and gynecologist at the University Kebangsaan Malaysia Medical Centre in Kuala Lumpur. And she was before this the Dean of the UKM Faculty of Medicine as well. She has been the director of the UKM's teaching hospital, and she is a Senate member of the university when she was elected in 2020. She is also a council member of the Malaysian Medical Council, and she is a member of the Malaysian International Representative Committee for the Royal College of Surgeons, Royal College of Obstetricians and Gynaecologists. So she has been in many administrative posts, and she has been given the honor of being elected a fellow of the Academy of Science, Malaysia. She has published more than 100 articles in journals, many book chapters, and she is associate editor and the editorial board of 3 international journals, the Frontiers in Medicine, Frontiers in Surgery, and BMC Pregnancy and Childbirth. And I have had the unique honor of serving with her on one of those journals, namely the Frontiers in Surgery journal, on one of the research topics. She is at present heading the Health Technology Innovation Lab at UKM, and her current research interests include medical virtual reality, 3D animation for medical and healthcare education, and interestingly, medical drone development. And maybe we should hear something more from her about that, and mobile app design for antenatal care. She is the vice chairperson of the Malaysian Society for Simulation in Healthcare and the immediate past president of the Perinatal Society of Malaysia. She is a trainer in the intensive course in obstetric emergencies under the Malaysian Society and a research committee member for the Society for Simulation in Healthcare. So I can go on and on, talking about her various achievements. But on a personal note, I would like to say that I have known Zaleha, if I can call her that, for the past, I think, more than 7-8 years. And we have worked closely together in a number of fora. And I can vouch for the fact that she is an extremely pleasant person. I have never seen her lose her temper. She is, there's a lot of lessons that I can learn from the way she tackles interpersonal conflicts, and she's a very active researcher and takes on whatever work is given to her very happily. And you wouldn't believe when you interact with her that in reality she is such a senior person. So it gives us great honor to welcome you to this forum, Professor Zaleha. So thank you for accepting our invitation. Thank you.
Thank you so much for the kind introduction, Dinka, if I can call you that. Yeah. On first name basis, we are friends. And yeah, I'm so grateful to be invited to give this talk. I don't consider myself an expert yet in simulation. We are all learning. And I would like to thank the faculty and the dean particularly, and the medical director for giving me this chance to give this lecture. So if I can share my screen now.
You can, madam.
Yeah.
I've already enabled.
Okay, right. I'll put it on full slideshow. Yeah.
Yeah, madam, 1 minute. Can I make one announcement before you?
Sure, no problem. Yeah.
Yeah, I just want to tell the listeners that this program is being live streamed in YouTube as well as being recorded for posterior academic use. Please keep your mics muted so that the audio quality is good for everyone. Over to you, Dr. Zaleha. Sorry.
Thank you very much. So the topic today that has been given to me is teaching teamwork and non-technical skills in simulation. I was so grateful to be given this topic because I think it has got a lot to do with the field that I'm in obstetrics. There's a lot of non-technical skills and a lot of teamwork that is important in the crisis management where obstetric is concerned, and I'm sure in neonatology as well. And a lot of the time we work together, the obstetrics people and the neonatologists. And now over 2/3 of medical errors, which are called sentinel events, are primarily caused by failures in communication. And healthcare providers tend to be trained as individuals. We all are trained as individuals. You must know this particular procedural skills and things like that. But functionally, we are almost exclusively functioning as teams. And that creates a gap between our medical training and the reality where we work, wherever our workplace is. So because of this, the Institute of Medicine in USA suggested the use of simulation exercises focused on improving interdisciplinary teamwork as one of the mechanisms to improve patient safety. And I think this is a very important step that was taken many, many years ago. And I think we should all strive to follow in these important and useful steps in order to ensure patient safety. Now, maintenance of certification under the American Board of Obstetric and Gynecology has got some core curricular components that are highlighted. Okay, namely, there are 5 important areas: duration of training, participation in simulation procedures, technical contents of simulation, as well as instructor and versus student ratio. But very importantly, they highlighted the non-technical contents, management of relevant patient care scenarios with an emphasis on teamwork and communication. So that's one of the core components in the maintenance of certification program. So this is something that we should highlight. And among the, I'm sorry about the a bit blurred, I think, the slide, but I think these are some of the examples of scenarios for team-based simulation in obstetrics, you know, things like pre-eclampsia, eclampsia management, abruptio placenta, postpartum hemorrhage, a very well-known scenario for team-based simulation in obstetrics. Less commonly, thyroid storm is less common but very critical to be able to handle such things, such scenarios. As has been said, you know, there are certain less common or perhaps rare or uncommon scenarios that are important to learn as a team-based simulation scenario. Medical-wise, for example, diabetic ketoacidosis, cardiac arrest, those are the scenarios that are important, critical scenarios to learn, although they may not present themselves every day in your practice. And to some extent, scenarios can also be combined with procedural skills. For example, you can combine the management of sepsis or septicemia with intubation. Same thing with cardiac arrest. It can be combined with intubation. So you can actually mix and match certain procedural skills with scenario or team-based simulation to maximize this. So teaching of non-clinic technical skills is just as important as procedural skills. Traditionally, the medical profession had a hierarchical formation with experts at the top working autonomously. So, you know, it's like the consultants are untouchable, senior consultants more untouchable, you know, and there is a gap between the top of the hierarchy and the people working at the grassroots level. However, experience in the aviation industry has shown that crews that score highly on certain behavioral markers such as good communication, good leadership, management and situational awareness, these are the teams that operate better in critical situations. So effective teamwork and leadership in healthcare are vital as they reduce medical errors. And it is important in the making of a team of experts into an expert team, okay? Rather than having a team of experts with the experts sitting at the top, it is more important to form an expert team where every individual in the team is actually an expert in his or her own right. And that would make better teamwork. Okay, so critical aspects of an effective or high performance team are things like good leadership, good teamwork, and effective communication. Most importantly, effective communication. So in order to form an effective team, you have to have common goals among the members of the team. All members of the team must share short and long-term goals. And for clinical teams, the common goals should be patient-centered and outcome-directed. All members must be committed to achieving these common goals that have been mutually set among them. And every team member should have the knowledge, skills, and behaviors and attitudes that are necessary to perform his or her role in his or her area of competence. Okay, so every single member in the team is important, no matter whether you are a consultant or you are the clinic assistant. Okay, and team members must communicate effectively and efficiently with each other, the patient and other groups or individuals that are also important across boundaries. So communication is of utmost importance in forming an effective team. And coordination among the team members work towards making the team efficient and effective. So this is the framework for the formation of an effective team. You must have shared mental models, okay, meaning that everybody thinks along the same wavelength, okay. Very, very importantly, there must be mutual trust with each other, and closed loop communication is very important in forming an effective team, okay. Mutual performance monitoring is important. In other words, each team member keeps everybody else, on their toes in terms of their performance. If you see somebody else, having an issue that can be improved, in order to make the team more effective, then you should be able to freely voice this out. Okay. Backup behavior in terms of sharing of workload within the team, team orientation so that everybody knows his or her role within the team, adaptability to the situation. If suddenly there is an increase in workload, for example, each member of the team should be able to be flexible enough in order to change things around so that the extra workload can be absorbed, for example, among them. And very, very importantly, the team leadership, okay, should be somebody who, besides being able to give some direction to the team, can also acknowledge and accept criticism or comments from other team members and opinions from other team members in order for the team to work effectively. So these are the characteristics of high-performing teams. Okay, situation awareness in the sense that team members continually assess their environment and update each other. If you see that there are some things that need to be changed, you can tell each other. Okay, so in that sense, there is shared cognition among the team members. You are thinking along the same wavelength, all the time being goal-oriented. Do not lose vision of your goal. And in terms of leadership, it is very important to flatten the hierarchy. In other words, an effective team leader can both command the team as well as value the input from the other team members. You're not the only person who is smart around there. Okay, everybody else is just as smart as you are in his or her own right, in his or her own area of competence. Okay, that is something that you must acknowledge and accept. And the followership is a flat hierarchy. Every follower should be alert and outspoken and dare to verbalize observations within the team and keep the leader right. Okay, there should not be any threatening environment within the team. And closed loop communication is very important in the sense that, after the message has been sent, there has to be a signal that it has been received, understood, and action can be taken. Okay, and certain critical language and standardized practices should be in place. In other words, there is a common language that is understood by all. One example is ISBA. I'm sure those who are familiar with team simulation would understand what ISBA is. In short, it is identification of yourself, and then able to you are able to tell what the situation is all about, the most important thing at hand that needs to be handled at that time. You are able to give the background to the scenario, what exactly is happening, the background of it. You are able to assess the situation and finally give recommendation what needs to be done. And assertive communication is very important. You should dare to speak up for the sake of patient safety. Okay, and speaking up means talking in a respectful and non-threatening manner, and all team members are considered to have valuable input regardless of what your rank is. Even say the house officer, the person who is doing the lowest responsibility within the team, it doesn't matter. Okay, it is just as important as everybody else. And there should be adaptive behaviors with flexibility and trust among members of the group. And team members should be free to ask for help when overloaded. And there should be mutual performance monitoring. Everybody can tell everyone else how they are performing. And there should be backup behavior, if possible, even volunteerism and volunteering to take up more workload from somebody else if you happen to observe that someone is overloaded with the task at hand. And workload management is very important. Proper delegation, proper allocation of tasks, and avoiding work overloads on a certain group of people within the team. Okay, prioritization of tasks when things get busy, and preventing distraction and ensuring adherence to protocols. So you should be free to point out when there is non-adherence to protocols. Now, very, very importantly is debriefing, so that you optimize the lessons learned in the team-based simulation, okay? So that there is effective learning, and teams that debrief will perform higher actually in real life, okay? So the debriefing part is very important. These are some of the useful tools in communication. For example, as I've mentioned just now, closed loop communication, which means that the sender gives clear, concise, directed instruction to the team member, whichever team member that the message is directed towards. The person who receives the message read back the instruction to ensure correct understanding of the message, and the sender confirms that the instruction has been correctly read out. And finally, the receiver then accepts the task given to him or her, okay, and carries it out. ISBA, I've mentioned just now, identify who you are, situation, the main issue, whether it's postpartum hemorrhage or bleeding placenta previa or a cardiac arrest, whatever, okay? The background, okay, you should be able to describe the background to the situation, assess the situation, what you think is going on, and recommend what you think needs to be done next. Okay, then there is the call out or snappy, calling out in a crisis. Okay, the leader steps back, stops the team for a while, gets the attention of the team. Okay, and then inform the team of the patient status, notify them. Assessment here means your interpretation of the situation, just like the ISBA, and then what you think needs to be done in terms of the plan. Now, there are two additional steps. Priorities. You state the order for the plan, and then invite ideas from the other team members, okay? Meaning you seek input from the rest of the team, okay? And in terms of speaking up by every member of the team, there is the 3-step CAS model, for example, telling the team that you are concerned, you're not comfortable with what is going on, and that this is a safety issue. Okay, so everybody then should be able to pay attention to you. There is also the 4-step PACE model: probe, alert, challenge, and emergency. Okay, or the modified PACE model. In other words, the OSCE approach: observation, what do you observe, what do you suggest, and challenge and alert that this is an emergency. Again, effective tools for team communication. Always, you know, the ISBA would come up, okay, snappy, and then check back. All right. Those are the description of what ISBA is about, snappy. And for check back is a closed loop communication tool to ensure that the receiver of the information understands what the sender was intending to say. In other words, this is closed loop communication. Okay. So this is actually part of what is recommended under team steps. I would allude to that in a short while. So this is an example of a ISBA communication. Okay. The I sometimes drops out of the equation, but I think it is very, very important to identify who you are. Okay, whether you are the consultant, you are the specialist, you are the intern, or you are the staff nurse, the midwife, whoever. All right. And then go to situation. For example, baby boy Johnson is having persistent apneic spells. This is in a pediatric situation. Okay. And then an example of describing the background. Earlier in my shift, I added a blanket to maintain baby Johnson's temperature and noted he had emesis or vomiting. Following 2 of his enteral feedings, he also has a central line from his abdominal surgery 2 weeks ago. So this is the background to the problem. Example of assessment. I don't think he looks right, and I'm afraid he may be septic. Okay. And example of recommendation. I need you to come in immediately and assess the patient. He may need a sepsis evaluation. Antibiotics should be started, and if he continues to be apneic, he may need positive pressure ventilation. So this is an example of what ISBA communication is all about. So does simulation-based team training improve patient outcome? Are we talking on evidence-based medicine? Although measuring improved patient outcome based on the intervention, simulation-based team training is actually quite challenging, and only a few investigations were able to show a direct effect. There is actually enough convincing data suggesting its effectiveness. Okay, at least, for example, there are 3 examples here. Okay, Wayne in 2008 says that the proof that the quality of patient care improved during actual cardiac arrest after a simulation-based training intervention. Draycott in 2006, in a large investigation which included approximately 20,000 neonates, showed that simulation-based team training improved neonatal outcome significantly. Tim Draycott is actually a consultant obstetrician in UK. I had the opportunity to meet him when he came here in Malaysia. He did a lot of work on team-based simulation. Andrietta in 2011 showed that simulation-based training correlated to an improved pediatric survival rate after a cardiopulmonary arrest. So I think it is clear, and I hope we are all convinced that team-based simulation is important and work towards ensuring patient safety. A bit of history about team steps. Team steps stand for team strategies and tools to enhance performance and patient safety. This was developed in the USA for teamwork training in relation to patient safety since 2003. And Team Steps was actually the outcome of a multi-year research and development program led by the American Department of Defense and the Agency for Healthcare Research and Quality. And the Department of Defense in US has used the curriculum successfully throughout military healthcare and showed that it actually worked in ensuring patient safety. So this is the instructional framework of team steps. Okay, you have knowledge, attitudes, and performance. The 4 pillars to this is the leadership, communication, situation monitoring, mutual support, and very, very importantly is communication among the team members. Okay, there has to be a certain set of skills that the patient care team has in order to carry out this team-based, this teamwork. Okay. Right. Now, in the team steps curriculum, the outcomes that are aimed for a shared mental model at the end of the training. Okay, that's what we would like to have. The team should have adaptability, good team orientation, mutual trust with each other, good team performance, and very, very importantly, patient safety is the proof that you have actually done a good job in terms of the team-based simulation, and you end up with being able to ensure patient safety wherever you're working in. The tools and strategies that you use within the curriculum are things like brief, huddle, debrief, step, cross-monitoring, feedback, advocacy, and assertion, the 2 challenge rule, CAS, as we have I've mentioned just now, desk script, collaboration, ISBA, call out, check back, and handoff. What are the barriers to effective team-based simulation? If you have inconsistency in the team membership, you know, there's a high turnover in the team, it's very difficult to achieve effective teamwork. If you have lack of time for training, lack of information sharing, if you have a very defined hierarchy where the senior consultant or consultant in your team does not want to hear, you know, what people at the bottom are telling him or her, if there is a lot of defensiveness when you know, your performance is being commented on for the sake of improvement, if there is very conventional thinking, you know, not wanting to flatten the hierarchy, for example, if there is complacency among the team members in terms of wanting to improve yourselves, varying communication styles, not wanting to adhere to ISBA, call out and things like that, STEPI and all that, okay? If there is a lot of conflict among the members of the team, if there is lack of coordination and follow-up with co-workers, a lot of distractions, there is fatigue within the team members, there is a lot of disproportionate workload and nobody wants to back up each other, if there is misinterpretation of cues, lack of role clarity, all this will spell disaster within the teamwork. Okay, so these are the barriers. Barriers against successful team steps curriculum performance or, you know, implementation. So very importantly, everybody should have a mindset wanting to shift towards a culture of patient safety. Okay, you set the stage, decide what to do, make it happen, and most importantly, make it stick in the long term. I think that is a big challenge. Not easy, but not impossible. Okay, in the first phase, there should be assessment of the needs of the team. Okay, in phase 2 is planning, training and implementation in terms of this is where the simulation training takes place. And then phase 3 is sustainment in the long run. Okay, so pre-training assessment includes site assessment and survey of the work culture in that place. And there must be certain data. In other words, there should be smart objectives, measurable objectives. Okay, and at the end of this pre-training assessment, you should ask the team whether the team is ready to take on the team-based simulation training. All right, if it's not ready yet, then perhaps there should be some climate improvement, and you go back to assess all these three factors, okay, site assessment, culture survey, and data or measures. Okay, so if you are ready, you can go to the next level, which is the action plan. What simulation are you planning, and how are you going to implement it? Then comes the implementation stage, where you go on with the simulation training. Okay, this is where there should be intervention, there should be a test, pre-test, post-test perhaps, okay, and you should aim for a culture change, okay, coaching and integrating, monitoring the plan, and continuous improvement should be planned out. Okay, so it becomes a cycle from then on. Okay, from the culture change, after a while, perhaps a few months or a year, okay, you go back to the training, okay, and then you go back to the culture change. So in a way, it is very much like an audit cycle, okay, in order to maintain. All right, you go now to the phase 3, sustainment. Okay, maintain a culture of continual improvement. So it's a CQI actually, continuous quality improvement. So these are the team steps: knowledge, skills, and attitude. Okay, in terms of team leadership, okay, the ability to direct and coordinate the activities of other team members, assess the team performance, assign tasks, develop team KSAs, motivate team members, plan and organize, and establish a positive atmosphere. That is the role of the team leader. Okay, examples of such behavior is facilitating team problem solving, provide performance expectations and acceptable interaction patterns, synchronize and combine individual team member contributions, seek and evaluate information that impacts the team functioning, clarify team member roles, engage in preparatory meetings and feedback sessions with the rest of the team. Okay, and mutual performance monitoring involves everybody else. Okay, this is the ability of the team members to develop common understandings of the team environment and apply appropriate task strategies in order to accurately monitor teammate performance. Okay, so this is where you identify mistakes and lapses in other team members' actions, and then provide feedback regarding team member actions in order to facilitate self-correction. This is where a lot of tactfulness is called for in terms of speaking up in order to correct your team members' performance. What do we mean by backup behavior? This is the ability to anticipate other team members' needs through accurate knowledge about their responsibilities. Okay, so you should be clear about each team member's role, and the ability to shift workload among members to achieve balance during periods of high workload or pressure. So among the examples are things like recognizing by potential backup providers that there is a workload distribution problem in their team, and then from there shift work responsibilities to underutilized team members, and completion of the whole task or parts of the task by other team members. So, you know, it should be a very fluid team dynamics, and everybody should be happy with the reshifting of the workload. Okay. Now, adaptability is where there is ability to adjust strategies based on information gathered from the environment through the use of compensatory behavior and reallocation of intra-team resources, and altering a course of action or team repertoire in response to changing conditions, whether it's internal changes or external changes. Okay, so everybody, all the team members should be adaptable to these changes. Okay, Examples are like, identifying cues that a change has occurred, and assigning meaning to that change, and developing a new plan to deal with the changes. Identifying opportunities for improvement and innovation for habitual or routine practices. So, you should not be so rigid and, stick to routine and not being able to change when there are changes in the internal or external scenario. And you should remain vigilant to changes in the internal and external environment. Team or collective orientation means that there is propensity to take others' behavior into account during group interaction, and there should be belief in the importance of the team's goals, not the individual members' goals. Okay. Example, taking into account alternative solutions provided by teammates and appraising that input to determine what is most correct. Okay. And increased task involvement, information sharing, strategizing, and participatory goal setting. Okay. And shared mental models, and organizing knowledge structure of the relationships between the task the team is engaged in and how the team members will interact. Now, I've got an alert here that my laptop is losing power. Okay, I'll just get somebody to connect the power. Please get the, yeah, the wire, please. Thank you. I've got my daughter to help me here. Thank God. So shared mental models are things like, organizing knowledge structure of the relationships between the task the team is engaged in and how the team members should interact. And examples of such behavior are anticipating and predicting each other's needs, and identifying changes in the team, the task or teammates, and implicitly adjusting strategies as required. And very, very importantly, there should be mutual trust among the team members. There should not be any paranoid behavior, thinking that your colleague may have less work than you and you are being put to shoulder too much work, that sort of thing. So the shared belief that team members will perform their roles and protect the interests of their teammates is very important. Okay, so everybody should be trusting each other. And to this end, behaviors that are important are like information sharing. Okay, if you have important information, useful information that you can share with the other team members, you should do so. And there should be willingness to admit mistakes and accept feedback from the other team members. And always, this particular phrase will crop up in team-based simulation: closed loop communication. Okay, not only in the implementation of the simulation, but also in the long term as a team. There should be exchange of information between the sender and the receiver, regardless of the medium. And behavioral examples of these are following up with team members to ensure message was received, acknowledging that message was received, and clarifying with the sender of the message that the message received is the same as the intended message sent. And in this day and age of IT and social media, this should be so easy, with the possibility of forming a WhatsApp group and things like that, in order to be able to work well. Okay, if you are on a virtual platform. So these are steps in developing simulation scenarios. Okay, before the simulation, there should be a needs analysis. Identify your learning objectives. What scenario design would you like to adopt? Session scheduling. Okay, how frequently do you want the simulation to take place? How frequently is it needed? Dress rehearsal and participant reminders. Okay, during the simulation itself, orientation of the team members' roles, consent forms, scenario, what scenario is it, list the systems issues, particularly if you are doing an in situ simulation, you can actually address systems issues as well, because you are doing it where you are working. Okay, the debrief scenario, perhaps there has to be some didactic elements, evaluation of the simulation, and what are the research elements. These are also very important. Okay, that should be part of the planning as well before it comes to the simulation stage. And post simulation, okay, taking down the simulation, scenario modification, what are the things that should be modified for the future, solve the systems issues if there was any identified during the simulation, data analysis, publication and continuing education. This is actually extremely important, sharing it with people out there, you know, if not globally, at least at a national or local level. Okay, but it is so important for the sake of scholarship of teaching and learning, SOTL. Yeah. Now, fidelity is multi-dimensional in team training. It is not just the task trainer or whatever if you are dealing with, say, procedural skills simulation. But there is also the environmental fidelity, okay, and also the psychological fidelity, besides equipment fidelity. So the simulation type could be case studies or role plays. It could be part task trainers, or it could be full mission simulations. All this form part of the team-based simulation training. And how do you maximize the usefulness of simulation in team training? Is by planning it out well. Okay, you start off with a needs analysis and carefully tailor your training needs. What are your goals? What should be the content of your simulation training? And what are the evaluation measures to reinforce one another? Okay, then you use case studies and role play to train teamwork related knowledge and attitudes. You may use part task trainers as well to train teamwork related skills to the point of overlearning. This is during the preparation for the simulation to take place. We do not want any glitches in terms of usage of part task trainers during the team simulation. So before the teamwork simulation takes place, all these issues need to be ironed out first. Whoever is tasked with procedural skills should be able to use the part task trainers to the point of overlearning. And then you use full mission simulators to hone teamwork related skills under conditions of ambiguity, time pressure, and stress. You use post-simulation debriefings to reinforce the lessons learned during this training. And you must remember that training is not a one-time event, so you need to plan accordingly, meaning that there should be a calendar of training throughout the year, for example. How frequently you should have that particular drill, okay, over the course of a year, for example, okay? And then you would have accomplished your mission. Okay, so planning the team-based simulation is very important. Okay, so this would be like in the course of planning, you should remember that the three major components of simulation fidelity, equipment fidelity, environment fidelity, and psychological fidelity. And out of these three, actually, psychological fidelity is the most important for teamwork skills training. There is no direct relationship between the level of simulation fidelity and teamwork training effectiveness as usual. Okay, it doesn't mean that high fidelity, particularly that task trainers and things like that, you should have, very sophisticated equipment. Okay. High fidelity simulations can enhance the perceived realism of well-designed team training programs, but it doesn't compensate for poorly designed ones. So the design of the simulation scenario is actually what's most important. And instructional designers need to carefully tailor the simulation's overall fidelity configuration to match the goals and content of team training. Most team training programs will require different levels of simulation fidelity throughout the training curriculum. And this is the simulation needs, okay? At the procedural level, individual level, teams of teams, when you make it bigger, okay? And systems, and finally, systems testing, okay? For example, okay, at the procedural level, the clinician may wish to practice their CBC skills on a task trainer. Okay, individual level, clinician wishes to practice a case with an atypical arrhythmia. At the team level, an ED care team of clinicians, nurses, and all that may be running a GI bleed case. Okay, and from there, the ED may be interacting with the trauma surgery teams, running a blunt trauma case requiring massive transfusion, or ED is opening up at the systems level, opening new trauma base and needs to dry run patient care to ensure flow and equipment function. So the level of training can go from a simple procedural skill right up to the systems testing, and this would be these three teams of teams and systems testing is where team-based simulation would occur. Okay, and you should consider what are the needs in terms of equipment, what are the task trainers required, mannequins required, what are the who are the standardized patients you require, and perhaps you may even consider a virtual platform, okay, for such training to occur. The environment, it could be at a simulation center, or it could be in situ, or it could be virtual. Okay, so these are the three environments that you could consider in designing your team-based simulation, right? There are certain advantages of in situ simulation versus doing the simulation in a sim lab environment. Okay, for example, if you do it as an in situ simulation, the environment is known, okay, and is familiar to the team members. Okay, however, the disadvantage is that you lose cost of closing the procedure rooms. For example, if it is labor room, for example, labor room based simulation, you want to do it in the labor room, some parts of the labor room will have to be closed. So if you have only say 10 labor room suites, okay, perhaps you're going to use 3 of these for your simulation training. So that will be lost on that day or during that time for patients to come in. So if you have a very busy labor room practice, then it's not going to be very advantageous. Okay, in the sim lab, okay, the advantages is that you're prepared for simulation observation areas, and you've got all your audio visual and all that ready. However, the disadvantage is that it's a foreign environment, less realistic, and the direct cost may be higher in the sense that you will have to have the audio visual and all that in place. So the cost of setting up the sim lab would have been higher to start with. But if you already have a sim lab to play with, then it's not a problem.
Madam,
Yeah.
we have long to go, or
no, I think there's only a few more slides left. Okay,
we'd like to keep some time for the question and answer session.
Okay, yeah, that's right.
Thank you.
Okay. Team debriefing. There are certain required elements for a successful scenario debriefing. For example, discussion of the content of the scenario, evaluation of structure, expression of the attitudes of the participants, and provision of proper setting for the trainees to feel well tolerated to engage in self-reflection, a non-threatening environment. Okay, and there are certain barriers to effective team debriefing as well at the individual, team, and organization level. Okay, in other words, basically, in short, people should be open to discussion. Okay, and be comfortable to discuss shortcomings. Okay. And these are instructor and participant behaviors for successful team debriefings. Okay, as I said, basically non-threatening environment. Okay, and there are teamwork measurement tools that can be used in order to assess the effectiveness of the team-based simulation. These are some of the tools that are used in obstetric simulation. I'll just go through very quickly. Okay, and right. This is my last slide, or second last, I think. The key messages. Failures in teamwork and communication between healthcare providers account for a major burden of avoidable patient harm and treatment injuries. The curriculum for team training is well defined and based in theory and evidence. Simulation is an effective approach to delivering this curriculum. Teamwork training needs to involve teams who work together in order to overcome professional boundaries and needs in order to engage all team members in meaningful activities relevant to their professional roles. Development and delivery of multidisciplinary simulation-based team training requires multidisciplinary faculty and organizational commitment to overcome the many barriers to implementation, and simulation-based team training should be embedded in healthcare institutions and become part of business as usual for quality improvement and patient safety, what we call drills. Okay, this was, these key messages by Weller and Civil in 2018 sums up very well the conclusions to this presentation. And for the future, perhaps we should consider virtual reality-based team-based training. So with that, I thank you for your attention. If you could unshare the slides for me, please. Thank you.
Yeah. Thank you very much, madam, for that very nice talk. And you touched upon so many areas like which normally we don't discuss, like in the sense we keep talking about backup. Yeah, you talked about the backup behaviors, adaptability, and mutual performance monitoring. But what I really liked about the talk was you defined each of this rather than using big terms. Just what exactly do we mean? You actually said the KSA of various factors, and actually the talk led us from how you can make a team of experts into an expert team. So that was, I think, the key message for the entire thing. And not only it is reliable in simulations, and many of the characteristics of the high performance teams which you described are very apt for many other situations, like how we come together and work as a team for any major purpose. It need not necessarily be only patient safety. I think that is another very key factor which was the takeaway from your talk. Before we go, I would like to ask Dr. Vishnubhat for his comments and some questions if you have any, sir.
It's a very interesting and very technically good talk. One doubt in my mind, you are telling the monitoring within the group, isn't it? Should we have an external monitor also during the training? Because sometimes each one may be busy in their role. So,
yes. Yeah, you brought up a very interesting point, Dr. Vishnu. Yeah, even in my team training for intensive care, intensive course in obstetric emergencies, under the ONG Society of Malaysia, we do have external evaluators coming from time to time in order to keep us properly on our toes, make sure that we are heading towards the right direction. Yeah, I think it is very important. Perhaps there are two types of external evaluators. One is content evaluator, you know, and I think the other one is the technical evaluator in terms of the simulation aspect of the training.
Another point which I was thinking on is rotation of the roles. In a team, there will be multiple people. So once you fix the role, he will be doing that. So is it better to train everybody in all roles? You fix the roles and then train.
Right. I think there are pros and cons. It's good in the sense that, you know, so that the person, you know, goes through the drill repeatedly in the same role and works towards perfection in that particular role. However, I think perhaps occasionally there should be a change in role so that we can recognize how easy or difficult it is to be in somebody else's shoes. And I think it's only then that perhaps we can have a flat hierarchy, you know, so that people can understand, you know, how it feels like, you know, rather than being a consultant, being an intern, for example, you know? Yeah.
Although it was very interesting, and I think skill learning has come to the real scene because we have to train people. Otherwise, it may be difficult without the skill training. In the real life situation, maybe sometimes. So
Yes.
thank you very much. It was very nice.
Yeah. Dr. Zaleha, actually, in continuation with what Vishnu Bhatt sir asked, I also thought about this, whether we need to rotate roles. It depends on actually how complex is the role and also what is the skill level of people we are involved in. No? That if you put a 2x2 matrix, if the skill level is very high and the role is much more complex, then probably we can rotate roles. But if the skill level is very low, let's say like I'm training paramedics for certain aspects, maybe probably we need to stick to one role rather than sticking on to multiple roles. Like let them learn to do one aspect correctly before we do. No, that is another way of looking at it. You
Yes.
talked about
Agree with
mutual performance monitoring, and sir also brought out this issue of whether to have external monitors. So during your simulation training, have you come across conflicts because of this mutual performance monitoring? And if, because when it does occur, how do we manage these conflicts?
Right. Well, I must say that I have been lucky to be in this ICO training group where people are very tolerant with each other and there's hardly any conflicts going on. But I can imagine if, you know, there was once when we had training, the first time I participated in such simulation training, although at that time I was already a consultant, but I was actually training alongside interns, new medical officers, and people in such roles. And there was another consultant as well training together with me. And I think it was a lot of fun that we had training together. And there was really quite sort of like flattening of the hierarchy. And we were able to accept criticism all around the team. But yeah, if there are any hesitancy to drop your role, if you are the expert in the team, I think it's going to be difficult to blend in with the rest of the team for the purpose of training.
Thank you, madam. Dr. Dinkar, do you have any questions for madam? If you have.
No, I think excellent and thorough presentation. I just wanted to make a comment about the rotation of roles. Sometimes we do find that team leader role sometimes needs rotating, and some of the other team members may be needed to give other tasks as well. So while it is a good idea to have role allocation to the team at the beginning of the scenario, or whenever the resuscitation or whatever is going on, the teamwork is going on. Necessity, sometimes it may be, the team leader may have to start doing something, in which case it is his responsibility to physically assign the team role to somebody, the leadership role to somebody else, so that the team is not left without a leader. So some degree of flexibility needs to be there in the system. So I may be given the role for giving drugs, but suddenly there's a need for somebody to do CPR. I may have to go and start doing that instead. But then it is important for the team leader or me to see that somebody else is there to do the role that I have vacated. So I think that that degree of flexibility sometimes is required in clinical teams. Otherwise, I think it was a very nice talk, and thank you very much.
Thank you, sir, for that comments. And we'd like to thank Dr. Zaleha for making it's actually quite a tough topic to speak on. Like when we thought about how to teach non-technical skills and teamwork skills. And she made it very simple by actually taking up real-time examples in obstetrics. And she defined the KSA of teamwork and the team steps curriculum very nicely. So thank you, madam, for this very, very informative and engaging lecture. And if I were to go by the comments in the chat box, one Dr. Tracy Sain, she says it's very excellent presentation, informative, comprehensive, and educational. And you also have one more from Dr. Win Khan. So for the excellent presentation. So we thank you for a wonderful talk.
You're
and we
most
hope
welcome.
that we will get a chance to interact with you again sometime in the future for any of our simulation workshops. Thank you, madam.
Thank you.
And with this, we are coming to the end of today's session. I would like to remind the participants that next week we will continue with our Trends in Medical Education series, and we will have this topic on how to put integration works to work. Like how can we learn, what are the things that we can learn from the cognitive science or science of learning. And the speaker is Dr. Kadambari. She is the professor of surgery, and she is also associated with the NTTC, National Teacher Training Center at JIPMER. And she would be talking on this topic, how to put integration to work. What are the lessons we learn from cognitive science? So that's the talk for next week, folks. So I hope you would find time to join us. Till then, we would require you to stay safe and get engaged in productive work. Thank you very much. This is Dr. Mahalakshmi, Dean, Health Professions Education from AVMCH, a part of Vinayaka Missions Research Foundation, signing off for this week. Thank you very much. Bye-bye. Bye, madam.
Thank you. Bye.
Thank you, sir. Thank you very much.
Bye. Bye.